Hello everyone, and welcome to today's Scottish Drugs Forum webinar, which focuses on the uptake of COVID vaccinations by people with a drug problem. I'm Dave Little, CEO of SDF, and I'll be chairing today's session. We have a number of speakers today. Sharon Hutchinson of Glasgow, Caledonian University in Public Health Scotland will share research she has conducted with colleagues looking at the uptake of COVID vaccinations among people who have been on opioid agonist therapy at some point over the last 5 years. This will be followed by a short presentation from SDF's Katy MacLeod on views of COVID vaccinations by people with a drug problem we interviewed as part of our COVID study. Then we'll have two examples of good practice, one from Glasgow through Lisa Ross, Service Manager with the Complex Needs and Asylum Health Services, Greater Glasgow and Clyde NHS, and the second from Wales by Martin Blakebrough, CEO of Kaleidoscope. This will be followed by a question and answer session, where we'll also be joined by Brian Stevens from NHS Tayside, who has done some interesting work on ensuring greater uptake of vaccinations by people with a drug problem in Dundee. So without further ado, let's start with our first presentation from Sharon Hutchinson. Thanks, Sharon.
Good afternoon, everyone. And thanks to the Scottish Drugs Forum for putting on this webinar and for inviting me along to share some of the work that we've been doing at Public Health Scotland. If I can first acknowledge colleagues at Glasgow Caledonian University and PHS who supported this project, in particular Alan Young, who is the lead analyst on the project. So I think, you know, the background to this work is that expectation was that compared to the general population, people who use and inject drugs are at potentially increased risk of acquiring SARS-CoV-2 and also in terms of developing severe COVID disease because of the higher prevalence of comorbidities. But there have been few studies that have examined this and quantified the risk of COVID in this population. Most notably has been a study from the United States here at the bottom, whereby they estimated that the risk of a COVID diagnosis was as much as 10 times higher for people with a diagnosis of opioid use disorder compared to the general population. But they did focus here on a diagnosis of COVID, and that is very much influenced by the extent of testing and targeted testing in a population. And so we were very keen to kind of examine this in our own population here in Scotland. And so, you know, our aim was to try and quantify the risk of COVID disease, but also look at uptake of vaccination amongst adults here that have been prescribed opioid agonist therapy. And it's essentially a record linkage study. And so we've utilised information held on the prescribing information system at PHS. On individuals prescribed OAT, and we're able to link that up with other, with the COVID information and other healthcare data. And this has been approved by the Public Benefit and Privacy Panel for Health and Social Care. So this, just to kind of give you a sense of the size of the population we've examined here. We went back to records from our prescribing database back to 2015, and we had information up until at the end of 2020 on that cohort. So it's around 40,000 individuals that had been prescribed an OAT at least once during that time. And this provided us relatively up-to-date information on individuals that are on OAT, and it is fairly comprehensive. It's not entirely comprehensive because we were very much reliant on having what is called a CHI number, which is equivalent of an NHS number, which enables us to link it to our other healthcare data. And that's available for around 80% of our records. So it's not comprehensive, this data, and certainly not comprehensive all people that are in drug services, but it provides us an initial look at kind of vaccine and risks of COVID in this population. And for our analysis specifically on vaccine uptake, we confined that to individuals that are alive at the start of the vaccine programme in December 2020. And so we had to remove over 5,000 individuals had died before that time in this particular cohort. And we've got vaccine data here that I'll present today on up until the 24th of August.
We're not able to show the rest of Sharon Hutchinson's presentation because that data is not published as yet. So we'll now just progress to the summary slide and the rest of the webinar as recorded on the day. Thank you.
So if I can just wrap up and summarize our results, we find that people who have been prescribed OAT in the last 5 years, these individuals weren't associated with an increased risk of severe COVID disease. We also find that vaccination for both the first and second dose remains lower amongst our OAT cohort compared to the general population. And vaccine uptake was associated with a number of factors. It varied according to age group, comorbidities, also NHS board, not markedly by NHS board, but there's some variability in terms of that, the period and type of the last OAT prescribed. There are differences according to sex, deprivation status, and also we found differences according to the past Hep C diagnosis. So back to you. I'll stop sharing here, Dave, and back to you.
That's great. Thanks, Sharon. That's the third time I've heard your presentation, but there's always something more you pick up from it. So that's really helpful introduction to the webinar today. Can I move on now to Katy MacLeod, who's going to give a short presentation? Thanks, Katy.
So yeah, thanks very much for asking us to speak today. So I just wanted to share a little bit of our work from some of the peer research work that we've been doing around COVID impact. So we've been really seeking to search what's the actual impact on service provision and experience of services. So we've been doing this work in partnership with Glasgow University on the Icarus project. So there's a wee acknowledgement there. And also just to acknowledge the work of the SDF user involvement team and most importantly the peer researchers that have carried out the data collection as well. So I should give the caveat that we didn't set to look at COVID vaccination uptake or anything like that, but actually when we started looking at the qualitative data we saw that there was quite a few themes coming out that would be relevant today. So I'm going to just really summarise very, very briefly and just give you some illustrative quotes really from that data. So we're going to look at perceptions of risk versus the actual experience on the ground for people and how that translated to feelings towards catching COVID-19. We will touch a little bit on perceptions of the vaccine and just sort of finish off with the experiences and concerns of staff from the staff data as well. So I'm just going to really summarise the themes. What I should say is the majority of participants that we spoke to didn't actually know anyone who had directly been unwell with COVID-19. And that was really important in terms of how they felt about the risk and also what prevention measures that they might apply. So things like social distancing. So whilst we saw some people actually being, very concerned, that seemed to be much more correlated with having known someone that had been unwell, and then also obviously concerns about things like shielding and things like that, shielding groups or vulnerable people as well, where that was known. The majority of people that we spoke to also believed that people who use substances don't seem to care about COVID-19 in general. So that came across quite strongly. I would say that there was regional variation, so it was really interesting to hear Sharon talk about health board areas, and that was something that we definitely saw as well from this sample. The impact of the perceptions and vaccine uptake was really mixed. So again, those regional observations, and that came through not only from the Icarus data that I'm mentioning, but also actually anecdotally we're hearing that. So I think one of the things we were discussing when we were doing the planning for the webinar was we were actually talking about experiences within our peer research team and our wider volunteers at SDF and our addiction worker training project, and just speaking to people and saying, you know, what's it like out there, and people saying anecdotally that actually there seemed to be suggestion that there might be a bit of a lower uptake, and also interest in between that first and second vaccination as well. So sometimes people not returning for the second vaccination. So that's come out anecdotally as well from our other work. Staff also identified COVID-19 risk behaviours, and this impacted on concerns as well for staff. So thinking about their own well-being as well, and their own risk to their own household as well, and that impacted on some aspects for them. So those were the kind of major themes. So I'm just going to shoot over to some quotes just to illustrate some of these themes. Okay, and so yeah, you can see some of the themes here. So people who are mad with it don't care. It's other people who are worried. I feel like it's being overlooked. I don't know anyone that's had COVID, and I don't feel the people I met in the hostel last year or homeless people are that concerned about it. I don't think people in drug circles are thinking about COVID or are concerned about it. COVID hasn't changed. Drug use in my area, there's no point in using heroin without crack these days. Sorry, I'm just moving this from the screen. And I see people deteriorating, and these groups don't adhere to the social distancing and stuff. People say shoplifting has actually been easier. And then some other comments. So not really, it's been blown out proportion. I'm not too concerned, it is what it is. I haven't heard anything, but don't feel people are particularly worried. It's just seen as another thing. People also talking about no changes. They're not socially distancing and life is much the same. People talking about no worries, general feeling that if you catch COVID, it will be fine. And you know, another participant talking about not being worried. And then there was also the impact of people that had it as well. So people saying that, well, I had it back in March. My partner and I were ill and had all the symptoms, so they're not worried about catching it again. And the next participant talking about a couple of people, they've recently been diagnosed, but they haven't heard much more than this, and they're not personally worried about catching it. And then a final participant talking about not knowing anyone with symptoms. And this quote just highlighting as well about just some of the risk behaviour. So people congregating in a house with 6 or 7 people, probably not realising how much danger they're in. Folk are out trying to score and they don't care about the risk to themselves or others. And they're all from different areas. And they talk about their own experience of buying Valium. The dealer wouldn't deliver, and when I arrived to pick it up, there were 12 people in the living room. So I asked to be served in the kitchen, and the dealer said he wasn't concerned as no one had symptoms. And so in terms of the vaccine, like I said, we didn't ask specifically about this, but there was some quotes about it, and we also included some of our conversations with our peer researchers as well. So we've got a couple of quotes from them as well. So the participant here is mentioning conspiracies on Facebook about vaccines and stuff, and they don't know anyone who's actually had it. It feels fake and it hasn't impacted on me except going for their vaccine. I feel the vaccine's been forced on us, and I'm concerned about COVID passports. And then again, someone saying I caught it early on and I was fine, not many symptoms, so I'm not worried about getting it again. So therefore, weren't thinking about the vaccine for themselves. And then this person talking about getting the first vaccine, it knocked them out. They were so ill, there's no way they'd be doing that again, so they didn't go for their second one. And then this other person talking about they don't believe it, it's a big conspiracy, so I'm not getting the vaccine. It's all over Facebook and I don't buy it at all. I'll wait and see how it plays out over the next couple of years. And then finally, just a few comments from staff as well. So again, staff finding some of the same themes. This staff participant was talking about just the awareness of COVID being quite mixed. So some people maybe being aware of it, but not fully aware of all the elements of it, and saying that, you know, they didn't watch the TV, for example, didn't watch the news, and describing one guy who'd been charged by the police 6 times for trying to get into McDonald's in the first lockdown, you know, trying to walk around the drive-in, and there's no way he's going to pay. I think he got a £30 spot fine every time. And, you know, we had a long discussion about COVID, and he clearly hadn't a clue what I was talking about. You know, what do you mean we're not allowed to go out? because his world and his life at that time, watching the news and what was happening in society, wasn't a priority to him. It was surviving and every day. Another staff member saying that, yeah, they do see people taking it seriously and being concerned about it. This participant talking about most of them do, but there's still the odd few that will tell them, yeah, I'll not wear a mask, I'll do what I like, sort of thing. And then someone else talking about, certainly a few of mine have had warnings from housing because they're inviting folk into the house. They shouldn't be doing that. The police have been involved. They're getting complaints from neighbours, and so that's as well. And then the last participant just talking about how that can impact actually on their own household environment. So they talk about that anxiety, initially worrying that the family are all going to be okay and will we get through this, and trying to hold everything together and be strong while supporting people. One of the things that did come up as well, so just to sort of finish off, was to say that actually something that one of our volunteers had emailed in this morning. So thanks very much to Jim about that. He talked about his experience of supporting people and how it was actually, some of the people have been reporting hesitancy about getting vaccination, actually because of hesitation about getting an injection, because they maybe had history of injecting drug use and just feeling that they never wanted to have a needle in them again. So that's something that maybe needs further exploration, and certainly we haven't focused on, you know, looking at these themes specifically, but that was an interesting point, and certainly something I recall from my previous work with clients, you know, maybe around oral health, for example, being quite worried about getting you know, kind of injections and things like that. So maybe something for us to consider. But very short and very brief illustrative quotes, but certainly feel free to contact me at the address if you'd like any more detail. We will be publishing this report in conjunction with Glasgow University, but thanks very much for listening.
Thanks, Katie. That was really helpful presentation. We'll move directly on to our third speaker now, who's going to talk about practice from Glasgow. Lisa Ross, over to you, Lisa. Thanks.
Hi, and many thanks, Dave, and thanks for inviting me on. Okay, so as Dave has introduced me, I'm the service manager for the Complex Needs and Asylum Health Service, which is a city centre service in Glasgow. And I thought I would start very briefly just explaining a bit about what our service is. A lot of people will know that we previously were referred to as the Homeless Health Service. We're located in Hunter Street, and we're a service that provide a kind of one-stop shop model to a high risk and vulnerable population with multiple and complex health and social care needs. So previously the homeless health model consisted of various teams, so that's why most people would recognise the homeless addiction team and the homeless mental health team. All of those have now been merged into a single team, which incorporates homelessness, addiction, physical and mental health. We provide a rapid access to assessment, care and treatment. It's predominantly the same day access, and we engage with individuals for whom mainstream services haven't worked or haven't been able to be effective. The addiction element for us comprises the biggest part of our service, with around 200 to 250 on the caseload. The other service that I manage, and I'm only mentioning it is because it was relevant to this vaccination programme, is the Asylum Health Bridging Team. And they provide initial health assessments and ongoing support to newly arrived asylum seekers in the country. So when we looked at what we had done previously with vaccination programmes, all that we had here at Hunter Street was a yearly flu vaccine programme. And to be honest, it had kind of varying levels of its success and engagement. And we historically concentrated on our own caseload only, so only those people that were open to Hunter Street and accessing our service. So usually we would do around 100 to 120 vaccines a year. It was a kind of opportunistic approach, and as is mostly done through people accessing the clinics at Hunter Street. It changed slightly in 2020 during the pandemic, so we increased that and we did a lot of more kind of outreach locations and managed to increase the uptake to around 250 doses last year, which obviously for us was far better. So in terms of what happened in the pandemic for our service, so we remained a front-facing service, and just because of the level of risk within our caseload, we increased our face-to-face contact with people, but we significantly changed our mode of delivery of the service. So we moved it from what was historically an on-site clinic approach to an assertive outreach response. At the same time, the city centre hotels in Glasgow were accommodating around over 600 people who had presented as homeless during the pandemic. So the Glasgow City Council had accommodated people there. Now, our outreach work included to those hotels. And what we were aware of, that people in the accommodations, they weren't obviously all open to our service. Some were open to addiction services, but some were not open to services at all. Now, we were seeing on average between 8 to 12 new cases a week engaging with our service, and the majority of them had not engaged with services previously. So we knew that there was this large cohort out there who probably weren't open at all. Our previous clinic model, so that made it difficult for us in terms of looking at doing a COVID vaccination, because our previous clinic model, where we had 50 to 60 service users accessing Hunter Street on a daily basis, meant that we were obviously going to have to do things in terms of the vaccination again very differently. And same as is nationally and globally when it comes to the COVID vaccination, there would be little point in us just vaccinating our own caseload, although that would be valuable. But to be as effective as possible, we needed to vaccinate as much of the population as that we could, particularly that they were all living in really close proximity within the city centre. So the way that we did it, we teamed up, kind of tag teamed really with Bar Street, which is the NHS Greater Glasgow and Clyde Assessment Centre and Vaccination Programme. That was really ideal for us in terms of making sure that all of our nursing staff were adequately trained with delivering the vaccine. It also provided us access to the vaccines, because I think without that, that would have been very difficult. And the 2RAS recording system, because when we're out and about delivering vaccines to people who essentially we don't know, we need to be able to ensure that they've not previously been vaccinated. We were supported hugely by the HSCP commissioning services, so that we were able to receive information on every single person that was currently accommodated in homeless accommodations. I make it sound quite simple, and we kept it simple, but I can't underestimate this was logistically a massive piece of work for us, because we were obviously using nursing staff who at the same time hold really complex caseloads, and all of that work that we do within our own service had to continue whilst we were doing this vaccination programme. So basically we set up a 2-week schedule. We have a very small nursing team, and we split people into 4 groups. So we would have 2 staff working together, and we did the assertive outreach approach. Now, so we delivered this programme over 50 homeless accommodation sites. We included the asylum population who were in the initial accommodations as well. Now, the way it worked over those 2 weeks, that we would go to those sites multiple times, although we would have a clinic list, if you like, of named individuals that we were going to access. When we arrived, of course, at the accommodation, people would be out or people would be busy, and it rarely worked out that we actually stuck to a clinic list. So there was a mix of people that we expected to be there, and then obviously opportunistically people who weren't on the list as well. Basically anybody who would take a vaccine that hadn't had it, we did it. We also did some fixed sites in terms of mop-up clinics, which we did at our own service, the Simon Community Hub and the community pharmacies. We had runners basically going between sites, because we had to ensure that there was minimal wastage possible, and that was really effective, because on the majority of days we had no wastage at all of the vaccine. We were able to do that though because we were using the AstraZeneca vaccine. If it had been the Pfizer, the method of that outreach approach and that multiple sites wouldn't have worked. It's a much more fragile vaccine, and you have to really kind of stick to fixed sites when you're using the Pfizer, which I'll come to when we talk about the booster program. So in the first schedule, we managed to vaccinate 569 individuals. So they were all first doses. We would have been able to do much more than that, probably more than double, had we not been using the AstraZeneca vaccine, because obviously we were only able to vaccinate people who were over 30 at that time. The 84 of those vaccines were for the asylum population, and that was actually about an 80% uptake within that group, which we thought was good, particularly with the concerns that we had when we were delivering the programme right in the middle of Ramadan. But we had done a lot of kind of preparatory work with MERS and British Red Cross and the Scottish Refugee Council beforehand. When we did the second schedule, we did less, so it was 354 doses we did, and 232 of them were second doses of people that we had vaccinated the first time. The under 30s, we had to link to the drop-in centres and the city centre. There was a city centre vaccination bus that you may or may not be aware of, but the uptake for that wasn't high, which is what we would have expected. So Asylum service, they now have a weekly vaccination clinic, but it's much easier within that population to do that. So everybody who's seen through the week is offered the vaccination, and then they're booked to come back on a Friday clinic. Obviously, with our homeless population, and it's much more difficult to do that. What we ideally want to be able to do is an opportunistic vaccine, where we seeing new people every week. The difficulty is that if we're using, and it would have to be Pfizer for that, because of the wastage of doses, and we're not able to open a vial on a daily basis just to provide one vaccine. So we would have to kind of almost gather people. And as I said, that becomes really difficult to do in our population that we're working with. So we're hoping that maybe one day there will be a single dose available, which would hugely allow us to do so much more. So when we're looking now at the flu and COVID booster, because we're now at that time now, as I said, all of the challenges for us that it will be Pfizer and Moderna, so that has to be a fixed site approach. We'll be starting that around January time for the booster. The good thing is that we've got agreement now from Public Health to have the flu vaccine supply first, because initially they were keen that flu vaccines and booster were done together. But obviously we'll be able to do the flu vaccine using the exact same approach that we had with the COVID one, which is covering all of those multiple sites, and then we'll do the COVID booster separately at the start of the year. The BBV testing, what we did when we did the second schedule is that we thought we would use that opportunistically as a chance to provide dry blood spot testing for those people that we're vaccinating. Now, within our own service, because we remain front facing and we were testing the whole way through the pandemic, our own caseload is up to date in relation to that. But we knew that there was a large number, and still is a large number, of people in homeless accommodations who have not had a BBV screening done for some time. So we did that in the second schedule, and our aim is that when we start our flu vaccine in the next couple of weeks, we will do the same again, where we'll put a separate team out at the same time across all of the accommodations and provide dry blood spot testing. And as I said, the booster program will commence at the start of next year. I put in this thing about the mop-up clinics are ongoing. We have a very kind of transient population that changes on a regular basis. So for us, it's almost a constant cycle of vaccines, because when we go to do the second dose, we obviously also picked up people who it was a first dose, and the same will happen when we do the boosters. We'll pick up first doses and second doses again. So we are aware that this is just now going to have to be part of our remit in terms of this population and the vaccination program. Thank you.
Thanks so much, Lisa. That was really helpful and a great example of what can be done. I'd now like to ask Martin Blakebrough from Kaleidoscope to talk about what they've been doing in that fine country Wales. Thanks, Martin.
Hi, and yeah, data, I can more give you stories than data, and I hope that works for you. I'm not giving you any PowerPoint presentation, and I'll start back in February. I went to see my son, who just come out of China in 2020, and when I was in Malaysia, realised that COVID itself was going to be a big problem, not just for China, but also across the world, as you saw it move its tentacles across Southeast Asia. And I think what was clear to me, and I think the advantage of running an organisation in a relatively small country, is that you can actually feel you can make a difference. So the issue of face masks was very much on my mind, because if you look at SARS, it was going to be clearly going to be transmitted through the air, and while people were deliberating its value or not, we obtained the import license, so we could import masks from China. I think we bought about 100,000. We bought gloves and aprons, so we're pretty early on in that. But also it was about how do we make sure that Welsh Government doesn't forget our service users, and also how do we get the message across to service users about the potential risks of COVID. And very early in the COVID campaign, we managed to persuade the Welsh Government to provide small bottles of hand sanitizer, because one of the ideas was, in order to get a message, it's actually quite good to give people, one, the means to be clean. Obviously, if you're homeless, you don't have, or you're in a hostel, you're not necessarily having access to be able to clean yourself all the time. But actually giving people a small bottle of sanitizer was a practical thing, but also was a way then you could give the message to people about the dangers of COVID and ways of avoiding it, or ways that we thought then of avoiding it. We also started realizing that messaging was really important to our client group, and yes, giving things like face masks or giving people hand sanitizer was one way of getting that message. It was also, we set up a hashtag, leave no one behind, which again was to keep pressure on service users, keep pressure on Welsh Government to focus on our communities. We also felt, well, how do we get the message? The government messages, as has been said here, don't really resonate with our service users. They're not necessarily watching the BBC News. They're not reading local newspapers. They're very vulnerable to false messaging, and they don't really trust the establishment. So we learned a little bit. I don't know if many of you are aware of Naloxone Man, but it's been a very good campaign by George Charlton to raise the issue of naloxone. So we thought, well, could we adapt that? And we created, with a bit of advice from George, Vaccine Woman. And the idea then was that we could actually try and get some social messaging to our client group, which proved to be useful. And we would then, in our bases, we would have videos which would be from some of our doctors, some of our nurses, some of our project workers, vaccine women, about why the vaccine was important and why they could trust the vaccine. And I think that element is really important, that we help to convince people that that the vaccine is safe and also useful for them. We also were fairly quickly off the mark in terms of going, well, okay, if people are going to get their vaccine, is it going to work then getting an appointment to go to a vaccine clinic where they were giving the mass vaccinations out, given that we had persuaded Welsh Government that our clients should be a priority group. That obviously really, when it was initially tried, it just didn't produce good enough results. And we persuaded them that they could actually use our medical team to vaccinate people. That didn't work because of insurance purposes. But what was great, particularly in Gwent, which is part of Wales, was persuading, was them deciding to have a mobile vaccine team. So that meant that we could have the vaccine team in our bases right across Wales, but particularly in the Gwent area. So effectively, people were coming in for their methadone, or they're coming in for their Buvidal or whatever medication they were on, and then we were able to get them there and then to take the vaccine and be vaccinated by the NHS mobile team. And we were able to coordinate the data. So it was a sharing of data in terms of working out which clients were the priority clients and making sure that they were able to access that. The other good thing in Wales is we have the Vaccine Equality Committee, and because we were very forthright, and again, being a small country, being able to talk to our MSs, and in fact, during the COVID first few weeks, we'd have 2 MSs regularly on the calls with our substance misuse partners, explain to them what the problems were that we were facing. So it meant we had the NHS, we had the politicians, and we had the service providers all trying to make sure that our clients were a priority, but also that we were looking at strategies of how to make sure the vaccine worked for them. So the Vaccine Equality Group still meets now, but it includes third sector partners like Kaleidoscope, but also housing groups such as Camorth. So what has been really welcomed, as far as I'm concerned, is making sure the third sector are seen right in the middle of this. I mean, I asked our nurse what her views were, one of our lead nurses, And she said, very much in our joint working approach for public health and the NHS mass vaccination team, Kaleidoscope provided data of those that fell under the categories of priority vulnerable groups, and we commenced with mobile clinics in Newport and then rolled out and continuation of pop-up clinics throughout Gwent. And through that work with the drug services and Kaleidoscope in particular, it was then rolled out to mosques. In terms of vaccination team worked in mosques, in hostels, and then we started doing one-to-ones. So we would, our assertive outreach teams would identify people who may need the vaccine but with no fixed abode, so we could provide the vaccination through there, and making sure that the data was secure with the NHS as well. So the issue of double vaccination, which Lisa in the previous presentation mentioned, it meant that that was covered. So it isn't a perfect system, and I think the booster will be a problem for us because we have primarily relied on AstraZeneca for the reasons Lisa has given, because of the vaccine is easier to put into community services. So that's going to be a bit of a challenge for us, making sure the booster works for our clients. And also amongst our staff, there seems to be, not huge, but there seems to be more hesitancy about the booster jab. I'm not quite sure why there is that hesitancy, but obviously we know that if our staff aren't 100% on board and giving that message, then there is a danger of its effectiveness amongst our clients. And finally, linking to Katy MacLeod's reference, it is strange that actually we definitely had our clients, some clients who've had COVID, although it does seem relatively small number who are presented with any significant problems. And we're not really sure why that is. We've done surveys with our clients, and at the moment, it would seem that a lot of our service users feel that even though they've had the vaccination, COVID itself has not been a major problem. And maybe that's because if they're withdrawing or other health needs, that it's just one other health matter that's affecting them. So they might not really be aware that that's what's impacting with COVID. But anyway, that's just, I know we've only got 5 minutes, so I just thought I would just reflect on a few issues we had and some of our responses to that. But I think in Wales, it's been very much the third sector has worked together very closely with NHS, and I think that's been a really important thing.
Thanks, that's really helpful, Martin, to share your experience in Wales. If you just stay on screen, Martin, I can ask the rest of the presenters to come back as well, and we'll have a short Q&A session. And we'll also be joined by Brian Stevens from Tayside, NHS Tayside. And maybe start with Brian. Just if you want to, just very briefly, Brian, explain what you've been doing there, which I think will be useful for the audience to hear that as well, if that's okay.
Of course, Dave, thanks very much for the opportunity to speak. I will be very brief. So we've been in Tayside, we've been involved in a testing pathway for symptomatic people who use drugs. So all drug services in Tayside will refer patients into ourselves. We'll enable the testing team to go out to see them. Interesting with the data that Sharon was discussing. So initially from when we started back in May 2020, for the next 12 months, there was 280 tests, but only 6 positives. But since May this year and earlier this week, there was, out of 97 tests, 20 positives. So 1 in 5 patients who we're now seeing through substance misuse services. So I absolutely agree with what was said earlier about it doesn't seem real. I don't know anyone who's had symptoms. That certainly seems to be changing locally here at Tayside within the needle exchange of the patients that we see. We also got involved in vaccinations at a good 5 months or so ago using Pfizer. Tried initially to have set clinics, which were a disaster and were very poorly attended. So we now just have went to an opportunistic. We've got agreement and acceptance that there will be some vaccination wastage. We are 2 days a week currently. We have a vaccination clinic here at the Enhanced Needle Exchange Service in Dundee. So anyone who's in during the week is encouraged to attend on those days. So we've vaccinated about 89 individuals up to date. half are on a prescription of OST and half are not. And I think that for the half that are not, I think it's quite important to remember that the population, regarding the data on OST populations, those who are actively injecting and not involved in substance misuse services are probably more likely to get forgotten and are probably more likely to be in the high risk categories with other things going on. Just wanted to mention about what Katy had said, fascinating, and I think I absolutely agree, but risk for a population who are injecting drugs on a regular basis is a day-to-day occurrence. So it's the risk of COVID seems quite inconsequential when they're aware of the risks of overdose, of bloodborne virus transmission. It's not something which is likely to have an impact until they or someone close to them perhaps has had COVID and suffered badly as a consequence of it. But so I'll shut up now, Dave. Sorry.
No, that's great. Thanks for sharing that, Brian. Maybe just we could start just by asking all the speakers just maybe to reflect on what they've heard from others. Sharon, do you have any reflections first of all?
Yeah, no, I mean, I think it's very helpful to hear some of the frontline experience that underpins some of the data presented, and clearly there's been some great work done to do everything possible to increase vaccine uptake in this population. And whilst they demonstrate that, we haven't quite reached the levels of vaccination you see in the kind of the wider general population, I think it represents an achievement to date, but I think this is an opportunity for us to kind of learn from all of the experiences shared here, and how to take things forward. And obviously we've still got the winter to experience, and there's maybe opportunities here for others to learn from in terms of delivering a booster and indeed increasing the first 2 doses in this particular population.
Thanks, Sharon. Katy?
Yeah, I think just to sort of add to what Brian was saying, and just listening to the other speakers, just that low threshold access, that seems absolute common sense, about the opportunistic, ability to do that. That certainly would seem from some of the work that we would do that would be helpful, and particularly combined with some myth busting and a brief intervention. We know it works for so many other parts of public health and drug use. So it seems like that would be a really important thing to consider in service provision. Thank you.
Thanks, Katy. Lisa?
Yeah, there was a few things, and it's interesting that, and Martin had brought this up as well, in terms of when the pandemic first started, we expected a huge impact on our service users and our client group. We expected the fatality rate to be really high. And in fact, it's been seen the complete opposite, similar to what Martin said, and we do not know the reason for that, in terms of there seems to have been very little impact amongst our kind of homeless population. I know that Edinburgh have actually reported the same findings. Just interesting listening to some of what Katy was saying around the kind of perhaps the reluctance to have the vaccine, or that the clients saying that that didn't feel like it kind of impacted on them at all. We didn't find that. We found that our service users really engaged with us in terms of around COVID and what we had to put in place. Also, the vaccine, we didn't really find a lot of resistance to it, a very small number, but we again would have expected more than that. So it's been just really interesting. And I think my last thing is that, because we've spoken about this before, is that we're quite often concentrating on people who are prescribed OST and people who are open to services. And I think we have to continuously keep remembering about the huge number of people who are using substances that are not open to any services, and how do we get vaccinations to that client group. We've done a small amount, but there's still so much more, a bigger number out there. So yeah,
do you think your response from your clients has been because you're a trusted service to them?
Possibly, and I think yes, and I think part of it's probably because of the way that we changed our service delivery. I'm fairly sure that had we kept our old model, which to be fair we couldn't have done, that's probably played a big part, because as we change to the outreach, and I meant to say in the presentation, we will never go back to how we previously did things. This is how we will now continue to work, because it's much more effective, and we know that we have far better engagement.
Thanks, Lisa. And Martin, do you have any additional reflections?
I think the prison data is actually interesting, because in a way that shows you what the realistic outcomes you could achieve, because obviously there you're obviously captured. So you've got people who would only not be having the vaccine because they're opting out. And I suppose the challenge is as you say, Lisa, you know, with the outreach stuff, we've got to, you know, that is a way now that we can access people who aren't necessarily in treatment, as with Brian's needle syringe exchange. You know, that sort of cohort is really, really important for us to capture. And then it's really important for us to actually know what success looks like, a bit like Sharon was saying, you know. So if we roughly, or Katy, you know, if we roughly think that we should be hitting about 70 or 80% of our client group, then we've got to be asking a question, what are we doing wrong if we're not hitting that group? And I think that's, as I say, is about making sure that the vaccine is available when they need it, and when they're most likely to be able to accept that. But I do think that the Pfizer issue is going to cause us a problem. I think we were quite okay with the way things were in Wales. I'm not saying we couldn't have done better, but I think that's going to cause us real problems.
Thanks, Martin. Okay, I'm conscious that we're going over the allotted time, but I'll just turn now to my colleague Austin in terms of the questions that have been asked. So if we can just carry on for a few more minutes, I think that would be helpful for those that have asked questions.
Yeah, well, I think I can summarise it. There's the question that was raised, or the point that was raised through Katy's presentation. It came from an SDF volunteer about an awareness of people in recovery who are reluctant to get involved with anything involving an injection, or even attending a kind of in a medicalised environment, just because of their own experiences previously.
Should we stick with that one first, Austin?
Sure.
Martin, do you have thoughts on that?
Well, I mean, I suppose that the reality is it must be a relatively small group, because I do understand that people who have gone through injecting drug use and come through that use must be more reticent about needles. But the way that it's administered is very different. But I would then say the problem is, if you're in that recovery community, where do you actually access it? So, you know, we're good at capturing people who are in services, but if you're looking at trying to capture people who have moved out of services but are still very vulnerable, that again, I guess, would be where outreach works. But our outreach tends to be amongst more chaotic use. So I could actually see that group not only having a problem with needles, but also a problem for us to access them. And I don't know the answer to that.
Thanks. Anyone else want to come in on that one? Katy?
Yeah, no problem. It is definitely something I remember clients saying in frontline work, you know, about it being quite triggering, you know. For me, I think you raise an important point about actually, you know, maybe taking some of our clinics to where people are at as well. And I think that relates to Brian's point as well. So if we know that they're not engaged with statutory services, you know, can we be looking at different types of drop-ins? And, you know, obviously I heard sort of reflections from people talking about some of the mobile activities not necessarily being very effective at that point in time, but obviously that might change, particularly if we've got maybe more occurrences of positive tests in this population. So again, you know, maybe it's just worth like looking at those initiatives and learning from them.
Thanks, Katy. Austin.
And the other point is the influence of social media as sources of alternative sources of information, or sources of alternative information, and specifically, you know, a guy who's dedicated his own YouTube channel who claims to be a retired nurse, who, you know, goes into what is apparently medical detail about accidental intravenous administration, you know, leading to heart problems and so on. So you've got that kind of detail, and then amongst communities, whether that's people who use drugs or people in recovery, those stories spread. So I suppose it's about, you know, challenging some of that information.
I guess that is where I think things like the naloxone man comes in. You know, that peer, people who can be trusted within those communities, and using those people, I think, is absolutely key, as well as staff who, you know, are well trusted. If they're, you know, if they're outreach workers particularly, you know, getting them on camera to, you know, talking about, you know, the treatment, you know, more trusted information, I would say.
Yeah. Brian, you have thoughts on that?
Just, I mean, I was just thinking what was just mentioned about, I mean, trusted individuals. I think some service users will come back to get vaccinated. I mean, we've vaccinated more of the ones who came here for the first one have come back for the second. I think it's around 70% of those who have come in for the first vaccination have come back. There was a clinic 5 minutes walk away, which was the main clinic in Dundee, which none of them have attended. I think we need to work at all these different routes. I think that substance misuse services don't vaccinate in Tayside. Now, they have access to the population. They're seeing them on should be seeing them on a fairly regular basis for clinic appointments. If it's not getting discussed there, then yes, other services can mop up. But as it stands just now here, somebody who's in treatment would have to come to a needle exchange to get their vaccination rather than getting it within the health service where they're seen and key worked by services. It doesn't seem to make sense. There needs to be a far better coverage of vaccinations, as you mentioned, wherever the individual may be going. So, and wherever that relationship may be with specific workers. I think that's vital in order to get the numbers increasing. And interestingly, those who have come and had their first vaccination here, a far higher proportion have also then went on to have their second vaccination either at this clinic or a separate clinic. So I think having one and getting over that initial hesitancy about getting vaccinated is the best hurdle to have to conquer, so to speak.
Yeah, thanks, Brian. Lisa, do you want to add to that?
Probably going to repeat what other people have said. In terms of, I think Martin's right. I think it's just having that trusted people giving the right information, and we heavily rely on our service users to share information that we provide. The majority of our service has been built up over word of mouth, and the majority of our referrals are self-presentations and walk-ins. So, and I think just that, I mean, for us, you know, it was the outreach approach and getting our clients to then get that information out there. You know, social media is always going to be a nightmare for false information.
Thanks. Austin.
Yeah, and the last one is just about motivations for boosters. And I mean, to answer the question for you, I suppose it's you're a victim of your own success, but you know, people are worried about after the initial lockdown get their vaccination and don't have any problems. So why do they need a booster? So I suppose the question is, how do we encourage people to get a booster when motivation might be lower?
Sharon, do you want to take that first? I know it's maybe outside your remit slightly.
Yeah, I'm happy to kind of have a stab at that. And I mean, I think, you know, I think it comes back to getting clear messages out around why we have a booster program. And, you know, there's various groups, Public Health Scotland, Public Health, what was it, England, the JCVI have been scrutinising the data you know, all of the time on this, looking at how effective these vaccines are, and so it's on the basis of, you know, very strong data that indicates you know, waning of the vaccine, that it is why we have now got a program for the boosters. So you know, and I think it's whether those sort of messages, some of those messages are in the media, but it's whether those sort of messages are getting to this population. So it is you know, and I think it's just because, you know, it's a continuation of this. There's so many messages, but we're entering a next phase now. And you know, we need to kind of strengthen those arguments if that isn't present.
Thanks, Sharon. Katy?
Yeah, I would agree about the messaging and sort of echo what Lisa's point is. You know, I think that's the whole point of social media being an important place, because it's that peer-to-peer messaging. People will listen to, you know, their friend group and things like that. So I think we need to be tapping into that peer-to-peer element with this, and making sure they have access to the booster information, because I'm not sure that that has reached this target population effectively at the moment. Thank you.
Thanks. Martin, you agree with that, I guess?
Yeah, I mean, I think that the other thing that is difficult, I think where we found, actually some of the staff have made the point that is a point that the founder of AstraZeneca made, which was these vaccines should be going overseas. They shouldn't be, being used as boosters when a lot of the population, global population, I mean, I understand that point totally, but it is still the case. We've still got to get those boosters because we need to protect people as best we can. But there are slightly more complex issues at play with the booster in that sense. But I am still very much, and I've had the booster myself, very much about saying, but we've got a duty to protect people the best we can, and the booster is a way of doing that. But I'm just saying, I think that political argument, it's certainly probably more of our left-wing members of staff, let's say, or so internationalists, have certainly been voicing those concerns.
Thanks, Martin. Okay, I don't think there's any more questions specifically. Austin, is that right?
No.
Okay, so I think we'll bring the webinar to an end at this point. Just thanks everyone for presenting. It's been a fascinating discussion, and I think it's given us a lot of pointers for where to go next in terms of this. And it's also just to mention the fact that Scottish Government is planning to issue guidance to health boards on the need to target people with drug and alcohol problems to ensure vaccination uptake. And I'm sure this webinar has helped areas to think about potential innovations that they can make. So finally, I'd just like to thank all of you for attending, and obviously, again, a special thanks to all of our presenters and panelists for what has been an important session. So thanks again and goodbye. Thank you.